Welcome to the Indian Council of Medical Research Online Prescribing Skills Course 2020 for the Indian Medical Graduate. I am Dr. Urwashi Parmar, Assistant Professor from the Department of Pharmacology and Therapeutics from SGS Medical College and KEM Hospital, and today I am going to talk about prescribing for women. After viewing this video, please answer 5 multiple choice questions on this video and give a feedback. You will find these in the assignment section. This module has been made by me in association with the subject experts Dr. Anushri Patil, Scientist E from NIRRH, and Dr. Padmanath Samant, Professor, Department of Obstetrics and Gynecology from SGS Medical College and KEM Hospital, and this module has been reviewed by Dr. Nilima Shirsagar, National Chair at ICMR, and Dr. C.D. Tripathi, Director and Professor and Head, Department of Pharmacology, VMMC and Safdarjung Hospital. In the part 1 of this module, I had described the first 3 topics from the prioritized list, which were general principles of treatment during pregnancy and breastfeeding, contraception and anemia in pregnancy. In the part 2 of the module, I will be discussing the next 3 topics, which are urinary tract infection, vaginal discharge and dysmenorrhea. After completing the module, the Indian medical graduate shall be able to list the points that should be considered while prescribing medicines to a woman, prescribe rationally for common conditions encountered in a pregnant woman, example urinary tract infection, and prescribe rationally for commonly encountered conditions in women, that is vaginal discharge and dysmenorrhea. Let us look at a case scenario for a common disease condition in an Indian woman. Meena, a 19-year-old recently married sexually active woman, presents to the casualty with complaints of a 2-day history of urinary frequency, burning and urgency. She denies any history of vaginal discharge or itching, fever, chills, nausea, vomiting, back pain, abdominal pain or hematuria. She has no history of urinary tract infection or a sexually transmitted disease. Her last menstrual period occurred 3 weeks ago. Her husband denies penile discharge or burning on urination. On physical examination, she is afebrile with normal pulse and BP. There is mild suprapubic tenderness while palpating the abdomen. Urine analysis reveals 1+ protein and 5+ leukocytes. The urine pH is 5.6. The casualty physician diagnoses an uncomplicated urinary tract infections and prescribes cotrimoxazole. Let us look into the brief description of this common disorder presenting in an Indian woman. As an Indian medical graduate, before initiating the therapy, you should know that urinary tract infection is a common disorder at all ages and in both sexes. A healthy and a normal urinary tract is generally resistant to infection. However, for anatomical reasons, the female lower urinary tract is more susceptible to infection. Urinary tract infection may present itself in acute form, that is cystourethritis, that is lower urinary tract infection, or chronic form, which is associated with pyelonephritis. The 19-year-old patient from our case is suffering from uncomplicated acute urinary tract infection, whose treatment will be described in the next few slides. As an Indian medical graduate, you should prescribe a 3-day antibiotic therapy for the first attack of acute uncomplicated cystitis urethritis in a young healthy woman. This 3-day course has an advantage of reducing the rectal carriage of gram-negative bacteria and is not associated with increased recurrent rate in urinary tract infection. Before choosing and prescribing any antibiotic, you have to keep in mind the principles of rational prescribing of antibiotics. Remember that fluoroquinolones are not recommended as the first line empirical treatment for uncomplicated cystitis. They are used if organisms are confirmed. Cotrimoxazole is perhaps the best initial choice for the empirical therapy in a non-pregnant woman. It is cost effective and relatively safe. In case you encountered resistance to E. coli, nitrofurantoin 100 mg BID for 5 to 7 days is equally effective. It is important to know that a 3-day therapy provides complete symptomatic relief but may not achieve 100% bacteriological cure. You may extend the therapy to 7 to 14 days, which has a high clinical and bacteriological cure rate. While prescribing, keep in mind the following oral antimicrobial regimens suggested for acute uncomplicated cystitis, which are cotrimoxazole 2 tablets twice a day, trimethoprim 100 mg twice a day, nitrofurantoin 100 mg twice a day, or ampicillin 250 to 500 mg 4 times a day. Ask appropriate history before initiating the above regimens. For patients who are allergic to sulfa containing drugs, or in case of pregnant women, ampicillin, amoxicillin, cephalosporins or a quinolone is the appropriate alternative. There is a possibility that the 19-year-old patient in our case may be pregnant, for which amoxicillin with or without clavulanic acid, cefalexin, cefodoxime and ceftibutane are the safer treatment options. Hence, the drugs to be prescribed for the 19-year-old Meena are capsule amoxicillin 500 mg plus clavulanic acid 125 mg for 3 days, advice on proper measures for hydration and hygiene, and advise the patient to follow up after 7 days. Please refer to our reference material for the general principles of therapy for urinary tract infection. We move on to the next common disease condition, that is vaginal discharge. Aruna, a 26-year-old patient, comes to the OPD with a history of profuse foul smelling vaginal discharge for the last few days, associated with non-painful itching and redness of vulva. She gives a history of progressively worsening itching. She has tried some over-the-counter cream without much benefit. She has been sexually active since the past 8 months. She is currently on birth control pills. Her menstrual periods have been somewhat irregular since she began menstruating at the age of 13. Her last menstrual period was around 2 weeks ago, which lasted for 4 days with normal flow and duration. She gives no history of allergy to any medicine. Vaginal discharge may arise due to inflammation of vagina resulting in discharge, itching and pain. One of the most common cause may be due to change in the normal balance of vaginal bacteria or an infection. The common types of vaginal discharge are bacterial vaginosis, most commonly due to Gardnerella vaginale or anaerobic infections, yeast infections which are caused by a naturally occurring fungus called Candida albicans, and trichomoniasis which is caused by T. vaginalis, which is a protozoan. The type of vaginal discharge varies with the type of infection. You need to ask the patient appropriate history regarding the color and the odor of discharge, like profuse curdy discharge which may be due to candidiasis, greenish yellow discharge which may be due to trichomoniasis, or yellow or milky white discharge due to chlamydia, or fishy odor which may arise due to Gardnerella. Ask the patient if the discharge is associated with pruritus. To prevent relapse, you need to examine and treat the male partner also. Ask the patient about her bladder movements, that is dysuria, frequency of micturition, which are diagnostic of chlamydal infection. Inquire whether the patient is diabetic or no. Ask if the patient is on any hormonal contraceptive pills, as vaginitis may develop due to decreased estrogen levels. If the woman is pregnant, inquire about her last menstrual period. Also ask her about history of douches, pessaries or tampons. Also ask her history regarding any trauma and vaginal or cervical operations. While prescribing, keep in mind that the appropriate drug therapy consists of a syndromic approach, which is as follows. For the treatment of trichomoniasis, tablet secnidazole 2 gram orally as a single dose or tablet tinidazole 500 milligram orally twice a day for 5 days or tablet metronidazole 400 milligram twice daily for 7 days. For candidiasis, either tablet fluconazole 150 milligram orally single dose or local clotrimazole 500 milligram vaginal pessary can be administered. Oral fluconazole 150 milligram should be simultaneously administered to both the partners. For chlamydial infections, tablet azithromycin 1 gram should be given 1 hour before food. Azithromycin should be administered along with the above drugs as a part of syndromic therapy, as cervicitis also presents as abnormal vaginal discharge. If clotrimazole pessary is prescribed, patient should specifically be instructed to place the pessaries vaginally, as there is a high chance that the patient might consume the dosage form orally, leading to ineffective therapy. The patient should be asked to follow up with the doctor along with the male partner after the completion of treatment. The patient should be advised on the plan of action in case she or her partner misses a dose. Hence, the drugs to be prescribed to the 26-year-old patient and her partner are tablet secnidazole 2 gram orally as a single dose, tablet fluconazole 150 milligram orally single dose simultaneously to both the partners, and tablet azithromycin 1 gram 1 hour before food as a single dose. Ask both the patients and her partner to follow up after 10 days. Please refer to the reference material for drug therapies for specific and non-specific vaginitis. The last case study in our module is on dysmenorrhea. A 23-year-old unmarried girl, Latika, comes with a complaint of pain in the lower abdomen during menstruation since the last 2 years. The pain occurs for the first 2 days of her periods and there is no pain afterwards. She is unable to carry out her routine activities, especially during the first day of her pain, as she has to take a leave from the office on that day. During her periods, patient usually feels depressed and she also has mild backache. Dysmenorrhea means painful menstruation. Its usual onset occurs around the time when the menstruation begins. The patient usually complains of pain in the pelvic region or the lower abdomen, and it typically lasts less than 3 days. It may be associated with back pain, nausea or diarrhea. Young women commonly suffer from primary dysmenorrhea, that is, without any underlying problem, as is seen in our case. In the initial steps, you need to ask the questions on onset, duration and severity of pain and cycle, regularity, length, last menstrual period, duration and amount of menstrual flow. The investigation that needs to be advised by you is hemoglobin estimation. Keep in mind that dysmenorrhea can be treated with drugs having different mechanisms of action. Non-steroidal anti-inflammatory drugs like paracetamol, ibuprofen and mefenamic acid and atropine derivatives like dicyclomine are valuable in the treatment of primary dysmenorrhea. Other therapeutic options like combined oral contraceptive pills should be given from the 5th day to the 25th day of the menstrual cycle for 4 to 6 cycles, or dehydrogesterone 5 to 10 milligram twice daily from 8th to the 25th day of the cycle. Appropriate education regarding the use of hormonal pills should be given to the patient. Please refer to the reference material for the detailed information on the drugs for dysmenorrhea. Hence, the drugs to be prescribed for the 23-year-old unmarried girl in our case is tablet mefenamic acid 500 milligram 1 tab twice a day for 2 days, and tablet dicyclomine 10 milligram 1 tablet to be taken twice a day for 2 days. Hence, the take home messages are: The initial choice of drugs in urinary tract infection are based on the availability of the culture reports. In urinary tract infections, amoxicillin and cephalosporins can be prescribed safely in women who are likely to be pregnant. The therapy for vaginal discharge is based on syndromic approach. Non-steroidal anti-inflammatory drugs or hormonal pills are useful therapies for primary dysmenorrhea. Appropriate education should be given while prescribing combined oral contraceptives to a young unmarried patient for primary dysmenorrhea. These are my references. I would like to thank the RUMC committee of St. G.S. Medical College and KEM Hospital. Thank you for watching this video. Hope you are now ready for attempting the MCQs. Please access the MCQs in the assignment section and submit the answers. Please also complete the prescription evaluation as per the tutorial, which I hope you have already seen. Thank you and happy learning.